Welcome, everybody. Welcome to podcast number 87 of Tough to Treat. And we are thrilled that you are listening. And we are thrilled and thankful for all the testimonials that we've received on iTunes. We are currently on a mission to get 100 testimonials before we reach our 100th episode. So we have about testimonials in the 80s right now. We would love it if you, after this podcast drops, which will be on December 17th, if you leave us a review on iTunes after that date, we will put your name in a drawing to win one of our webinars that we've recorded over the past year. So we've got a number of them, Susan, right? We've got a lot of them. So we would really appreciate it if you could leave us a review. So 100 before 100 is our mission. And we are just finishing up our clinical mentoring program. And for those of you who are interested, stay tuned. It's been quite successful. And we will be relaunching that mentoring program next year at the beginning of the year. So please opt into our website, toughtotreat.com, to receive all of the information. You'll get a clinical pearl PDF and some great clinical pearls on sleep and persistent pain once you opt in, but you will also be placed in our newsletter and you'll get first dibs on the program coming forward. We are also, we're pretty busy now. We're launching a membership site for our podcast, and membership sites are quite common now. They're the thing in podcast land, and people do them because you get much more than just the podcast. And I actually have opted into many membership sites for podcasts, and so please stay tuned for that. There's going to be a lot of more of us on the membership site as well. So once again, opt into the website toughtotreat.com, and you'll get all of that great news. So now on to the podcast. My patient. This is one of my patients who actually came to see me over the summer here in person, and she came to see me with double vision. And I thought that this was an interesting one to talk about. I only saw her a few times because she had to leave New York, but this is not sort of your typical clientele. So I thought it would be interesting for you all to listen to the clinical reasoning and to get a better idea how to treat people like this who have been, she was MRI'd and she had all the tests and nothing came up. So this is sort of up to us and left into our hands. I hope you enjoy it. Thanks. Hey everybody, this is Erica Mello and welcome to podcast number 87. I'm with my wonderful co-host Susan Clinton. How are you, Susan?
I'm good, Erica. It's getting close to the end of the year.
I know.
And lots of great things happening, as you said in the intro. So we're really looking forward to seeing how 2021 starts to shake out and who's going to be joining us on some of our adventures.
Yes. And it's going to be better than 2020. That's for sure. So I'm moving on. So we're planning. It's kind of fun to plan for the next year. I know a lot of people do it. And I think we have a lot of great stuff coming forward. So anyway, I will get right to it. This is a patient, as I said in the intro, who I saw over the summer. And she was referred by another therapist I know who lives out on the West Coast. So she's one of these New Yorkers who's bi-coastal, actually. And she came to see me with double vision. And the reason why I'm bringing this up is because it started after the birth of her third child. Exactly. So for me, it was quite interesting. I'll just do a little bit of the history. Just to preface this, I only saw her, I want to say 3 times, to be honest, because she had to leave New York. But I thought it was worthwhile to discuss this because it's so relevant to her. She's postpartum. And this is not something that we typically see as therapists, but she had an MRI, she had a head scan of the brain. None of that was, irremarkable. So let me give you her history. So she has 3 children. The double vision started 8 months after she gave birth. She has 3 children. The oldest one is 8. The second one is 2.5. And the third one is 1.5. So her belief is that the proximity of the last 2 births so close together has a lot to do with her current symptoms. So that's her belief.
Mm-hmm.
And what she told me, she, saw physio, as I said, in the West Coast. She was getting a bit better, mostly sort of neck work. She had went to see an ophthalmologist, had a workup there, nothing really remarkable. She had an MRI of the brain, nothing remarkable there as well. I don't have the results just as per her report.
Mm-hmm.
She also told me that she felt very compressed on the right side of on the left side of her rib cage. She's right-handed. She has help at home. She does not work outside of the home,
Mm-hmm.
so she spends a lot of time with the children. And her births were all vaginal. And her movement history, she does Pilates, some yoga. I asked her about any kind of incontinence. She had no urinary issues, stress or otherwise, during or after the delivery of her children. She does wear an IUD, for whatever that's worth.
Mm-hmm.
She has had no other major injuries or movement related problems. The only other thing besides the compression on the rib, she had subjectively, she had some right sided low back pain when she does a bend over. She also suffered a motor vehicle accident 5 to 6 years ago. No loss of consciousness, and she does suffer from headaches, which she takes Topamax for. Her other surgical history would be on her left wrist. She had her appendix removed about 6 years ago, and sleeps with 2 pillows, and she just takes vitamin D3 as well as multivitamins. She did tell me that when she gets the double vision, when she looks up, like cervical spine extension, it makes it feel better. And when she closes one eye, it also makes it feel better. The meaningful movements for her were looking down. Like she said, she had it all the time, but whenever she looked down, it sort of jacked it up a bit. And I also looked at an arm lift because of her rib issue. So do you have you want to comment on that, or should I just keep going?
When this is very interesting. I'm not surprised there's an MVA in the background here.
Yeah, yeah,
And
yeah.
it's does she have, and so right now she doesn't have any other symptoms like knee swelling, hand swelling, finger swelling, anything that would
No,
make you think RA
no.
or anything in there. I mean, because postpartum RA is kind of one of the autoimmunities that can get switched on. The reason that I'm thinking that, especially with looking down and making her symptoms worse, is that I'm wondering if there's like it just kind of makes me feel like, gosh, is the alar ligament intact?
Mm,
Is I know that that's going way, way, way down the road, but I know people can be somewhat symptomatic with just
mm,
a ligament laxity in one of those alar ligaments, and they don't have to be full blown. But she's got headaches.
yes.
Needs to be on top of Max 4, and that started after the car accident.
Uh,
The headaches
yeah. I mean,
start.
she's had it
Yeah,
for a long time. Yeah,
yeah,
yeah.
and she's on. So she's in that, and then the births being close together. There is some evidence that that can be somewhat problematic for the second child. It can also be somewhat problematic for the mom, mainly
Mm,
because there wasn't a lot of time for recovery if you
right.
have two kids 1 year apart, because that's like kind of having almost like a 9-month twin. Immediately getting pregnant right after you deliver. It looks like she about 3 months later she got pregnant again,
Yeah,
which
yeah,
it happens. And
yeah.
but I mean that's her belief too. So you kind of have to just kind of take that along with her, because we don't want her to feel like she did herself in, though. I mean, sometimes these things can happen even if there were 2 or 3 years, after
Mm-hmm.
the first birth, especially this kind of stuff.
Yep.
It's interesting though, after the second child, she didn't have this issue. It was after the third child. Because
Right.
the car accident was before the second child, after the first, but before the second, if I'm looking at my
Correct.
timelines right.
Correct.
Yeah.
Correct.
Yeah. So it just kind of makes me wonder, and that's what I was thinking. It's like, gosh, is there some sort of like, RA or something that maybe is creeping up? Because, rheumatoid arthritis can affect the ligaments in the upper cervical spine,
Yeah,
obviously.
yeah,
And,
yeah.
we
It's a good
certainly don't
point.
want the dens pressing into the cord, but she's not having cord signs, which is interesting. It's almost like more of a, kind of like double vision is kind of almost more like a, not even an ophthalmologic kind of problem, but maybe a sensory ophthalmology problem from the trigeminal system. That
Yes.
could be that
Yeah.
upper cervical piece. Maybe her upper cervicals, area has been heightened or sensitized, car wreck, one pregnancy, headaches, Topamax, another pregnancy, and boom, and that may just
Hmm.
be kind of the expression. Those are some of the things that's kind of where I'm going there is like,
Yeah, yeah. Yeah, no, it's
and
interesting.
that wouldn't be picked up on MRIs or ophthalmology exams or anything else. But it
Mm-mm,
is
no.
interesting that when she bends over, because then I think about the stretch, the dural, kind of stretch there. If she's got a sensitized trigeminal nucleus in that, upper cord, that could be, maybe that was kind of one of the things too. Just it just kind of got
Hmm.
the gain just kind of got raised on that. Interesting.
That's that's what I was thinking, Dura. That was right after her subjective. That's what I was thinking.
Yeah.
And she sleeps with two pillows. I'm like, well, you may not want to sleep with the two pillows. I just, just during the subjective, I was like, yeah, you
Yeah. Let's
know,
get you out of that flexion.
exactly. So that was her basic history. Not long, but very specific. And
Yeah.
and so once again, I only saw her two more times after that. But I will tell you what I looked at. Knowing the history, did I spend a ton of time looking at her posture? Not really. Okay, I did look at her neck, and I just assessed her, center of mass like I always do, just because it's the thing I do. And pretty centered, a little bit to the right in the pelvis, excuse me, left in the pelvis, right in the thorax, a little bit. Her head was pretty centered. Other than that, she looked pretty okay in standing, no major deviations. I did look at the front of her face. So there's one thing that I like to look at the depth of the eye sockets.
Yeah.
And her right eye was deep. I always write right. How I write it is right sphenoid posterior, but her right eye socket was very deep. I had her read um, a piece of paper that, like, just to read the vision wise, just to see like something that she would never read, like something out of like a book I found. And then I had her read it, and I just said, note how that feels, or not feels, note what that looks like, and if you have a problem reading it, or if it provokes a headache. So she did that. And then, I went into her, and did an assessment I had her got in the table. Had her in sitting, and I just assessed. I went in to feel the OA, just to see if there's any kind of compression through there, just all
Mm-hmm.
soft tissue tone, your sort of standard eval, in sitting. And I did find that she had a little bit of OA compression on the right. She's not a jaw gripper, not a bruxer, none of that.
Mm-hmm.
Because I did ask that.
Mm-hmm.
But what I thought was interesting, she had a lot of like a tendency in sitting to sort of shift her head to the right, C1, C6, C7, all just increased tone, a lot of just, a lot of stuff going on the right side. And, if you're looking for like, the biomechanical people listening, she just had like a right translation of her C-spine, but it could be muscle activity. Her upper traps were so tight. I mean, she was like holding her shoulders as earrings. And I wrote on my piece of paper, double, triple arrows here. So that was something that's probably just her strategy, trying to protect herself.
Did you
Uh,
did
other,
you at any point? Sorry to interrupt. Did you at any
mm,
point did you do like a sitting slump test? I know we were already
uh,
kind of talking dural, like when she looks down. Is it worse if she's standing or sitting?
I
She's
did that.
sleeping on a pillow, two pillows at night.
I did that the second visit.
Okay,
I
okay.
did. I
Stay
did.
tuned. All right,
Yes,
I'm with
I
you.
did do that. Yes. So, and then I wanted to validate her rib thing because she had mentioned it. So I went in on her upper ribs, and and she was very sore and tender. Just to sort of, she wanted to feel felt there, and I was like, you know what, I'll just feel felt. And I think we
Mm-hmm.
need to do that for patients if they're, they need to know that we looked at it, air quotes here, on air quotes, that we looked at it. Once again, she had your typical, shifts one left or the other. I mean, she's carrying kids. She's going to be biased to one side. So that's what I found in like in just sort of sitting. I did do a ligament test. That was tough for me to do on her. I didn't, you know,
Not much guarding. Mm-hmm.
yeah. And so I did assess her just general rotation. she was pretty good. She didn't really have any major limitations. She was pretty hypermobile, so she had full rotation. When she looked down, which is what I assessed, I said, when you look down, are you getting double vision right now? Is it making it worse? And she said, not this second. So it's not something she feels constantly, although she sees constantly. So it was something that was probably one of those things that comes every so often, although patients say constant, it's usually not constant. So what I ended up doing was I ended up having her look down, and then I had her read the piece of paper after to see if it was changed, even though, because she wasn't getting like double vision, and it was no change in vision. So it was okay to begin with in terms of reading. Like, it was like, my dog ate this. It was like really random words, like they made no sense. So I had her look down and I checked her vision after, and it really wasn't changed. No worse, no, nothing. It was okay to begin with. So that didn't make it worse, which is what I thought it would do. I just used that really quickly to assess.
Yeah, I think that's a great test, because I think some of the things that we think about too, like on the NDI, the Neck Disability Index, one of the things it talks about is sitting and reading, and I'm just wondering if perhaps maybe when she first looks down or she glances down, it's not a big deal, but if she's sitting there reading or, with her head down for a bit, that's enough to kind of start, it may take a little bit to bring it on.
Yeah, exactly. So, yeah, exactly. So,
and you don't know if it's worse in the morning or like right when she gets up, or if it's worse as the day goes on.
I asked her, she said it was no, her headaches are worse in the morning, but her double vision is not.
And she's taking Topamax, huh?
Topamax. Yeah, that makes you loopy.
What her blood pressure's doing.
I know.
That makes me wonder about her blood pressure.
Yeah. I tried that for my headaches. That was no good for me. So what I also did, I'll just do real quickly. So what I ended up doing is I tried to modify the movement. I said, look, I'm not reproducing her double vision in forward bending. I can't reproduce it right now. I'm just going to I just had her do a few repeated movements of it. I didn't want to have her bobbing her head up and down. I had her do a few times. I had her pick up something. I had her go down to the floor to squat, to drop her head, anything that we could try and get her to drop her head. Then I went up, and then after that, I went in and I felt. I just visually looked at her rotation. I felt. Did she have all this muscle tone on the right? Did it get better? Did it get worse? Was she still guarding in her upper traps? So what I ended up doing is I ended up going up in her CV region just to give her a little bit of decompression, just to take out some of that compression on the right side. And then I had her look down. I had her read, did the rest of her neck look better? Yes, it would look better because I'm intervening in her neck and I'm kind of making it feel better. It would look better because I'm taking out a little bit of that compression on the right side, but nothing else got better. Like, it was just nothing else got better. So what I ended up doing then, because you know me, I always just go into the upper thorax. So I went in and gave her a little bit of decompression there. I had her look down. No change, nothing major, no worse. But bear in mind, she was not getting double vision at the time I saw her. So I had to go on what I saw. So then I went into her, some of her lower ribs, and I just did some decompression there, and I had her look down. I wasn't getting anywhere. Okay. I was like, this is not happening. Okay. So what I ended up doing is since she was supine, so I had her in sitting, I got her in supine, tried the Ligament Test there. Then I said, you know what? I am just going to try some dural, like glides and neural stuff in supine, rather than doing this. The slump I did the next time. So I ended up doing just literally, I had a bolster. So I had her in a tabletop position, and I said, can you just get don't look up, I had her in one pillow. I put one pillow on, and I said, can you just drop your chin a little and just kind of keep it there? And I said, can you flex your ankle and just do a straight, like do a knee extension? So she was doing like a straight leg raise, tabletop knee extension. And I said, let me know if that reproduces anything. And I'm feeling things, right? And she's like, oh, I can't do that. I'm like, okay. So I took a pillow out, and I'm like, can you do that without the pillow?
She couldn't do it because,
like, she could do it, but she wasn't going very far. And this girl's hypermobile. I mean, so she was in a tabletop position, flexed ankle. All I did, I said, lift your ankle up, lift your heel up, and try to just straighten your knee. and she went up like halfway. Okay. And I had tested that before I put the bolster underneath her, and she was pretty good. Okay.
Interesting. Yep.
Yeah.
And
So
she's
then
sleeping on 2 pillows.
correct. So then what I did is I'm just looking at my notes here. I ended up having her, I went in, I took the pillow out, and then I just supported her a little because I didn't want that cervical extension, you know, because cervical extension made her feel better. I wanted to see if I could hold her head in neutral and see if I could feel like sometimes you get these like Bert and Ernie heads where you can feel a pull. So I just literally put her head in neutral. I had her do a little, like, I don't want to say chin tuck, just nod her head a little bit.
Right.
And so I had her do the same thing, and I felt a huge pull in her head, like she was, like her head was going, like the turtle was going into the shell.
Like as soon as it pulled, she was being pulled down.
Correct. And then, so I took the bolster out, and then I had her do some lower trunk rotation in the same position to see. I didn't change anything. I just took the bolster out, or the thingy out, and then I had her do trunk rotation. I felt the same pull. So I said to myself, there's something dural in the head that is driving this, because when I'm not finding something, or when I'm not reproducing something, when something doesn't make sense to me, I always kind of go, I mean, we always look to the nervous system, but I literally go and I'm trying to like lengthen the system with movement with people like that. So I'll stop and I'll let you comment.
No, this is kind of where I was going with the seated slump test. I was just wondering if in sitting it alleviates somewhat or worsens somewhat versus laying down, because if she has problems with her head leaning over, is it because it just takes longer in the upright position than it does in the laying down position? Or I don't know. I was just kind of thinking, that those were my things to kind of consider, was like, okay, if we're thinking a little bit dural, if we're thinking sensitized trigeminal, sensory experience here, there's something that's sensitizing that. And, this person has been in a car accident, has had 2 kids, and there's some talk in the literature, it's very small, on evidence about labyrinthine kind of things that can happen with heavy pushing, in vaginal deliveries. There's a thing called dizzy mommy syndrome, where women have quit, they drive, they won't sit in the backseat of a car, they won't ride rides, because they just can't, since and they tell me that. I haven't done that since I had my kids. There's no way I can do that now. So there's things that, that can occur. We know that, but this is not, I think the closest thing we came to talking about this once on the podcast was the young lady I had that had terrible urgency after the birth of her child. And we were really looking to see if there was a movement component to it. And when she stood up and bent her head down, that brought the urgency on. So we kind of, we unpacked that a little bit back in that podcast too. And, so this is kind of interesting that it's following a little bit of the same kind of thing here.
Yeah, it's postpartum. Yeah.
Yeah, it is. But is it postpartum coincidentally, or would this have happened? So that's the thing, was it because she had 2 pregnancies and 2 births that made this occur? Or was this already happening, and that just, what I'm saying, maybe 5 more years down the road, if she never had 2 other kids, would this have started?
Yeah,
it's hard to say. Hard to say. Yeah. I don't, nobody, those are one of the things that we have to ask ourselves, because we don't know. We just know that they kind of correlatively occurred along this timeline, and that's her belief system for sure.
Yes.
There's maybe a little bit of evidence to back up some stuff, but what we're finding, you hang your hat on, is the physical piece, the dural piece, that there's definitely some drag in the system there. Is it enough to sensitize? Well, if you add everything up, maybe it was already sensitized, and now that drag in the system is just keeping it going.
Yeah.
And
the third child was
and then these headaches,
Yeah.
I don't,
it's
this
funny.
Is all very sensory.
Like
which is.
I was just going to say that even if I put my hands on her head, like, when you're getting your hair washed, just put because the 3rd visit I just got in and did some cranial, like she was taking deep breath. Like she just wanted someone to touch her head, and it's just, it was very interesting. And For me, it's like the postpartum. Is that the reason why it's her third child? Because she believes that. I like the dizzy mommy. I didn't realize there was all that research. I just think that was relevant for her.
Mm-hmm.
Yes, she had a MBA, but anyway, when you add it up, it's all,
Mm-hmm.
it all makes sense. Her wonky rib, that's secondary, which I treated, but
Right.
that's
It might even
secondary.
help her neck feel a little bit better. You
Exactly,
know.
exactly. So what I did was to start, that was the eval. And then, so I told her to take out at least one pillow when she sleeps. And because that is provoking headaches in the morning. Okay. But what was interesting, because I did ask her if she drove. So here in New York, no. Okay. But back on the other coast, she did. And that was a little bit problematic, but she wasn't driving when I saw her.
Mm-hmm.
So what I ended up having her do a ton of just supine movements, taking one pillow out, putting another pillow in. I had her do bolsters, knee flex, knee straight, lower trunk rotation. I literally had her do teeny little nose clocks. We do
Mm-hmm.
pelvic
Yeah.
clocks.
Yeah.
I put a little towel under the head. I just gave her teeny nose clocks just to start, and lower trunk rotation side to side. I ended up having her do heel slides. I mean, you can make this up. I mean, you can lift one arm, go cross midline. So that was just the first visit. Okay.
Mm-hmm.
Then the second visit she said she felt a lot better. I think that was just treatment, just the therapeutic effect from the evaluation, because I did so much in her head. Uh,
Well,
so
she also
uh,
felt heard.
Yes, and she said that she was able to sleep better, and I was like, "Oh, you have a problem
This is the thing.
sleeping?"
Why was she? I wanted to go back and ask you this. Thank you for bringing that up again. Why was she sleeping on two pillows?
I don't know.
That's
I don't know.
like,
I didn't even
why were you
ask.
doing that? Because that wasn't
Hmm.
hell. Waking up with a worse headache in the morning.
I know.
And then you find this kind of dural, like the sensory stuff in that dural drag, and it's like, oh. So she got
Yeah.
off the pillow, you got on
She
her
got up.
head, you helped her breathe a little bit,
Yes.
and she felt heard, and she's not a crazy person, so
Yeah. Yeah.
yay.
Yeah. I know.
So
And
can't
it's
wait to hear
funny.
what's next.
No, I mean, it's just more of the same, to be honest. I mean, I ended up
Uh-huh.
getting her, so I just had her get on the wall. So I did a lot of hands-on, because she really wanted me to get in the head, and I'm happy to do it. I've done some cranial work before. I've taken, some courses, and I did that. And honestly, it's not like I'm like moving a suture. I'm just just
Sensory
easy,
input.
soft,
You're just
exactly.
touching all those nerve
Kind of,
endings, and
exactly,
it's comforting.
exactly.
Hmm.
That's exactly right. And she like, she couldn't wait to get on the table. She was just like already on the table before I even like
She probably
got things organized.
never gets a moment of peace either in her life,
I know.
with three
I
kids,
know.
like
Three
crazy,
kids.
crazyville.
I know. And she has help, but she's home a lot, and
Hmm.
her husband's very busy. Not actually, that's one thing I forgot to mention. Her husband isn't there a lot because he's traveling.
Hmm.
Ironically, during this time, still doing that. So he was not there a ton at the
Hmm.
time. So what I did in the second visit, I did more of the same, just more sensory input into the head. No, if anybody who's listening, did I do like, joint mobilization to the neck? No, I did not. I just literally had her do some movement. I put my hands on there. I just did some release of some of the soft tissue. However, we do it. We all do it differently. There was no methodical. She's hypermobile. She doesn't need her joints mobilized. So the only reason I had my hands in there is ironically, it changed her breathing pattern. It changed how she moved. And that's what we want. We want to change their movement. We could have them
Hmm.
stand on their heads, but if that helped, right? So
What were
that's what I
What were
ended up.
the arrows like on the upper traps this time? I know that you
Less
said in
like
the
two. They were still hot, but they were two. I
okay,
had four
because
the first visit.
so
They
already
were,
50% change, just
yeah,
or close
yeah,
to somewhat, a
yeah,
significant change.
yeah. And it's interesting because she didn't really have like the typical like back pain postpartum, no DRA, none of that. Like these were not her symptoms, these were not her complaints.
Hmm.
It was the visual.
Hmm.
And I think that,
This is where the sensitization hit her.
yeah, yeah. And I think
Hmm.
the MBA certainly was relevant. She's definitely a good coper. She's very strong willed. So she has good coping skills. She just,
Hmm.
she's not one of these people who's, you know, like she's like, I'm moving on. I'm like, she's very sort of forceful. And so she was able to cope with a lot of that. And, you know, so I did test the slump in the second visit, and it was negative, of course. Didn't really do anything, you know. So I didn't want to have her sit there and drop her head, you know, like for like the entire time. I did not give her that as an exercise. Bear in mind, I only saw her 3 times because she had to leave the city. So what I ended up doing on the third visit, okay, I ended up having her just added some arm movement, to be honest. She was still sleeping better. She still had some double vision. I ended up just doing bent knee raise. So head in neutral a little bit just to support on a towel, bent knee raises, lower trunk rotation, heel slides, arm lifts, reverse flies with arms. I had to do head rotation. I was just having her move different regions of the body to lengthen the system in ways that are non-threatening to her. Then what I started to do some eye tracking of this stuff that we talked about earlier. That is why I was so bummed she had to leave the city, because I was really starting to do the eye movements and the eye tracking. And
and I love this because that's a motor system thing. People forget that the eyes, the head, the neck, the balance, it's all part of the movement system. And there was a disruption in it, but can we help it retrain and find a new pathway and some neuroplasticity around that? So go ahead. Sorry, I was just excited.
But I wrote down that I had her do her head. Just I said, don't move your head, but move your eyes left to right. And that actually gave her temporal pain, both sides. So eyes moving to the right, moving to the left. And that was not like the best for her. She really felt like gripping right more than left.
Yeah.
So
that is definitely that whole tie-in with the upper cervical and the system as well, and her, her balance system, proprioceptors. Remember, there's 50% of the body's proprioceptors are in the upper cervical region. So the disruption and all of that, she's the double vision may be her brain trying to figure out the new equilibrium. And I think it's fascinating. So you can look at that as a symptom. When she turns her eyes and she feels something, it's like, don't go that far then. Let's play with that, because that's like finding the edge. It's like raising up your shoulder and it hurts at the top end of the range. Well, then let's stay out of that range and really start building the capacity around it and see if we can get it up higher, or let's find out where else needs to move better so that shoulder can actually get to the top range without symptoms. And you were like really experimenting with the eyes and really kind of finding, wow, there's some real restrictions within that, but that's a huge system if you think about what the eyes have to do. That if every time she turns her eyes either way, that she gets that, guess what she's not going to do? She's not going to turn her eyes.
She's not going to turn her eyes.
She's going to like deviate like crazy, because it feels, because that's no good. Awesome.
And so, that was my last visit with her. She was improving, and I was like kind of really bummed because, this was an interesting patient for me, and it's not something I typically see. And I think the whole eye movement, the whole trigeminal system is something that I'd like to do more work in, because I do think it's so important. And how I would have progressed her, I'm not sure. I may have just had her follow, do when she's doing the arm movements, have her move her eyes. I don't know if you have any other thoughts, but have her just follow her.
Yeah. Start with that. You already started her though in supine in a safe position doing the little eye clock. So you already began to introduce that system in, and, work with that. And then of course, you can have her follow things, as her legs go right and left, she can go opposite with her eyes, so you can, crisscross midline back and forth. All of those things are, things that, you can certainly do. And then you can keep progressing her up into more and more of the upright postures, to challenge her system a little bit and see, is it worse doing that eye movement in standing than it is laying down or sitting? Kind of what is the challenges to the system?
And I think that, I agree. I think that I'm just thinking here, I'm always like a step ahead here in my brain. I probably, as like talk about like checking the system. For her, it was really, she didn't really have a check. Like I had her use the reading, but it was not, as long as I wasn't making anything worse, as long as her reading didn't get worse, I was okay with doing things. In terms of like her reset was really just going the first few visits, was just going on just doing her nose, her eye clocks with some lower trunk rotation. That was sort of like a reset for her, to be honest. And
yeah, sleeping on, or maybe even kind of just laying down, but not with two pillows. Like, just resting her system. I would even think that probably, wherever she is, even if she just could, to just be quiet, close her eyes, and a few of those breaths that you were working with her under when you were decompressing the ribs, don't ever underestimate, everybody out there, the power of breath. Wow.
Yeah.
I mean, because it really significantly, I think, was probably one of the things that really helped her the first visit was you got her quiet. Her system got quiet for a little bit. And it really liked that. And like you said, she couldn't wait to get back on the table the next time she saw you. It's like, let's go.
I know. No, seriously. She was halfway seated. I'm like, I need to clean it. It's like, it's like, you got to move off. But so she was just so it's interesting because obviously something worked. Okay. But the double vision was something that was still going on. And I knew I wasn't going to get rid of it in 3 visits. So, the reason why I wanted to talk about it is because she associated with giving birth. And I just is it coincidence? I don't know, maybe.
I don't know. That's the question. But like I said, there's some evidence. There's not a lot of it, I can tell you. You guys go out there and you start looking. There's I did a CSM talk with Scott Yuppie and Carrie Pagliano on this a few years ago. And we talked about this and some various presentations and things like that. And there's some evidence, but there's not a ton. And it's one of the reasons is we're not asking the questions.
Yeah.
And it's like, so we're not researching what we don't know because we don't know it exists.
Right.
So one of the things I've been doing, and since you brought up the postpartum, is the ladies that I see, I ask questions now around equilibrium, balance, and dizziness.
Yeah.
All of them. They don't think it's relevant. They've normalized it. They've learned to live with it. I just don't ride rides. Where do you sit in the car when others are in the car? I drive. Do you ever sit in the back seat? Oh, no, never. Never do I sit in the back seat. Like, because it throws they can't do it. So it's just very, very, very interesting that you ask the questions, you start seeing more and more people who have this stuff, and they're just not talking about it because they just, again, some of this stuff, like for her, the double vision didn't start till 8 months later.
Yeah.
She decided that it was not just because she had a baby, but because she had two so close together.
Yeah.
But for other people, it may have just been because she had a baby, and then they're thinking, well, and then 8 months later, this comes on. They don't even associate it with that. They just and then they learn to cope with it and deal with it because they got to move on. And they just quit sitting in the back seat. And they quit doing rides and they quit doing things that makes them feel bad, like dizzy or awful or whatever it is. And so, and they're, they quit in exercise. Even they quit doing some of the different exercises they may have done because that brings it on.
Yeah. I think with the double vision, that's what got me. It was like double vision. That's
it's
really
an
not normal.
interesting presentation.
Of
symptoms for sure. I would think that when we talk about, just to kind of wrap this up in that package too, about reset exercises, and the exercises like when this does this, then you do this. That for you, you found that one thing when you turn your eyes side to side and you feel that temporal kind of pressure or whatever it is that she was describing. That's when you go do a reset exercise.
Yeah.
Exactly. If you can kind of turn your eyes pretty easily without that going on, you're okay. When that starts, it's time for you that's a sign that you need to settle your system, or reset, or, whatever anybody likes to call it. But I think that's fascinating that you got her quiet enough that she was able to actually start reporting those things that she, with her upper traps being 4 arrows and and all the tension and stuff you felt, she couldn't listen to any of that because the noise was so high.
Yeah, exactly. And I think it's for the listeners, you know, I like when I'm like looking at somebody and I'm not getting any headway with just some of the movement corrections that I do. I really try to go into the dural system. I could have done the slump. I just, once again, didn't do the second time. I just wanted to get her on the table. And I did some of those lengthening. You can do median nerve, and you can do whatever, you know,
all of them. Yeah.
And I wanted to see if I could feel because I wasn't getting anything subjectively from her at that point, except reading. I wanted to see if I could feel anything. Do I feel a pull somewhere? You know, is the turtle going inside the shell? It was going inside the shell. For sure. So that I would encourage people who are listening, if you're sort of stuck on somebody like that, I mean, this is a unique presentation. Try that. Try these different, you know, neural movement patterns. I mean, all movement's neural, but I mean, ultimately try to lengthen the system with some movement and see where you go. I mean, it's how you learn, I think, at the end of the day.
Yep.
So we hope you enjoyed this. I certainly did. And I wish she'd come back to New York so I can treat her again. So not meant to be, but that is that. Thank you, everybody, for listening. Enjoy.
Yes, thank you. Have a great holiday season. And we will see you for podcast number 88 before the first of the year. Right before the first of the year.
New Year's Eve it drops.
Okay.
Bye.
Bye.